Good morning, and today I'm going to be explaining to you the simple extraction procedure. We're gonna start by reviewing, greeting our patient, walking them to the room, having them take a seat, reviewing their health history. Do they have any contraindications to the anesthetic? Are they taking any blood thinners like aspirin? If they are, we would need to make sure with their doctor that it is okay for them to be off of it for a while, because a patient will need to be off of it prior to procedure to get it out of like their bloodstream, and then after the procedure when everything's done, so their socket can form a blood clot. And so we're gonna need to make sure with their own doctor if it's okay if they're off that blood thinner. And then we'll go ahead and explain the procedure to them, answer any questions they have, clarify any concerns, and then once everything is fine, everything's cleared, we can have them sign the consent form. And once that consent form is fine, we can go ahead and start taking vitals on them. We'll take their blood pressure, their respiration, and their pulse, especially in complex like surgery. And we want to make sure that their blood pressure isn't high, that their pulse is super normal. We don't want them to have a heart attack or anything. And then we'll go ahead and give our patient the post-operative instructions, and these instructions will be given to them before and after their surgery. After their surgery, they're obviously going to be a little woozy, a little dizzy. They might not even remember. And so we can give them a hard paper copy. Should have the doctor's phone number, the office's phone number, doctor's email, just in case they have any questions, concerns, if anything is going on. And then if they have somebody who's with them, somebody who's going to care for them after, then we can go ahead and give them as well a hard copy, only with the patient's consent. And then now we're going to make sure that our doctor has everything. We're going to start with our basic setup, our mouth mirror, used for indirect vision and direct lighting. Our explorers, when we administer the local anesthetic, the doctor will go ahead and go in with the explorer and poke the gums, make sure the patient is actually numbed up. And then our cotton pliers or cotton forceps, and our air water syringe, our 3-way air water syringe, to make sure he has his suctions, his high volume evacuator suction, his small suction, and then his surgical aspirating tip. Like I said, these can either be heat sterilized like the metal one, or plastic and dispose of like the bottom blue one. And when that is done, we're gonna, I almost forgot, 2x2 gauze or 4x4. These are cotton pads, cotton angles, cotton rolls. So we're going to be using like these, either 4x4 or 2x2, depending on what your doctor prefers. And then we're going to go ahead and use the topical anesthetic to numb the area. And once that's numb, we're going to go ahead and go in with our local anesthetic, which includes our cartridge, our syringe, and our needle. And then when that's done, the doctor is going to poke it and make sure the patient is all numbed up. We don't want to start and all of a sudden they feel this gigantic, ginormous pain. That's the last thing we want. And then our doctor will go in with the periosteal elevator. It's pretty smooth. This is used to loosen the gingival tissue, to go under the gums to help detach the ligament, to basically create room for the forceps that are going to be hooked onto the tooth, so we can try to pull that out. And then we're going to go in with a straight elevator. The straight elevator goes directly between the teeth, and the doctor rotates it. We try to luxate, he tries to luxate it out of its socket, which means to dislocate the tooth from the socket. And then once there's enough movement, the doctor will go ahead and go in with his forceps. There's many types. The most common one is the 150 forceps, maxillary teeth. 151 for mandibular. And then if we were working on anterior teeth, we can use the straight forceps. Now these forceps are used to remove the tooth in one piece. That's our main goal. We don't want to break the tooth. We don't want the tooth coming out in pieces. Our goal is to have it come out in one straight tooth. There's also these crown horns that are used only for the mandibular first and second molar. So 18, 19, 30, and 31. We'll be using those. And like I said, our plan or our hope is for him to not to break it. The doctor will grab the tooth with the forceps and kind of like rock it. There should be already enough movement, already enough room for the forceps, so you don't have to kind of like jam it in there. And then the tooth is removed from its socket. The doctor will go in and make sure everything is in contact, the crown, the root, especially the apex. And he will make sure that nothing's broken, that there's no root pieces in there, because if there is, then obviously that would need to be removed. And then next, the doctor will use a curette, a surgical curette. This is to remove any debris or infectious bacteria or tissue inside the socket. And we can go in with that 2x2 or 4x4 gauze and just kind of wipe it off. And then with the aspirating, the surgical aspirating tip, this one, we can go in and suction any debris from the socket, but make sure that your doctor wants you to suck up all the blood and the debris, because sometimes doctors actually want that blood flowing, and they so they'll go in and they'll try to like scrape the walls or like scrape the sides to promote blood flow. And then with that 2x2 new 2x2 gauze, we're gonna go ahead and fold it and place it into the socket wherever they got that tooth extracted from. And we're going to put it, like place it on the socket, have the patient bite down for 30 to 40 minutes. So you can put pressure on it to make the blood clot, because obviously you just had a tooth extracted, and so you might be bleeding a lot, depending, of course, if your blood is thick or not. And then there's usually a lot of blood on it after, so it's a nice gesture to go out of your way and not to change it multiple times, but to at least change it before the patient leaves, so they don't go home and their gauze is completely just full of saliva and full of blood. And while you're doing that, while the patient is holding it in their mouth, patients tend to like not swallow. So they don't swallow, not the dirtiness, but the debris in their mouth and the blood, nobody wants to swallow that. We tend to want to spit it out. But go ahead and tell them and let them know that it's okay to swallow their blood. There shouldn't be any debris. There shouldn't be any, like infectious, like tissue or nothing. So go ahead and let them know that it's okay for them to swallow. And then, of course, like we'll give the patient extra gauze, just in case they need to change it themselves. And then sit them up slowly. Of course, they might be dizzy, depending if you use like nitrous oxide or not. And re-give them the post-operative instructions. And with their consent, the person who is caring for them, or if they came somebody. And then when if they got up and they're feeling really dizzy, then that's when let them rest, and then go ahead and let them they can be dismissed when they're feeling better. And it's usually a good idea to check up on them either that evening, but if not that evening, especially the next morning, either the office, we can do it, or the doctor should have their information so the doctor can go ahead and follow up. But even if the doctor does follow up, our office, we should follow up with them ourselves to see if they have any questions or concerns. Is everything going fine? Is there, swelling? Do they have a lot of bleeding? Anything that can happen, just make sure that the patient's doing okay and healing just fine. Thank you.